by Dr. Aditya Kapoor. You know him well, and he'll be talking about conflicts of interest in detail, and then you can have your questions after that. Thank you.
Hi, good evening. I don't think many of you know me well. Only about 6 guys who are in the third row know me well because they are from cardiology. So, okay, so conflict of interest. How many of you think luring you with a chai and samosa and then inviting you for another lecture is a conflict of interest on our part? So, because मैं देख रहा था जैसे जेल के कैदियों को दोबारा बुलाया जाता है against your wish. But no, my talk is not very theoretical, it's just philosophical. And Dr. Vinita has been, tirelessly doing these courses over a long period. So at some point of time, you might feel कि पता नहीं इसकी कितनी ज़रूरत है, but I'm sure at some point of time later in your lives, you will realize that perhaps a fraction of what is being told is actually important, right? So we'll be discussing few points as we go along. And at some point of time, this slide structure, I would also want you to, I'm sure you guys are probably, your generation is much better than us in presenting or in making slides. So, but the slide structure should be, aisa hona chahiye, it should be grabbing the viewer's attention, not a very crowded slide. So that is another indirect offshoot of this presentation, right? So पहले दो चीजों के बारे में we'll talk about. You learned in the previous lecture by Dr. Piyush what is a conflict of interest. So if anybody wants to say what according to you is a conflict of interest, we want it to be slightly interactive. So what is your perception? Then you look surprised, iska matlab tum hi se puch raha hai. So just your perception. It's an informal thing. You can keep sitting.
Somebody publishes something, somebody else can say it is not there because it's copied.
Yeah. So you take somebody's data and publish without consent. So that is one sort of dimension of conflict of interest. Anything else? Anybody?
When all the authors are in
sorry?
When all the authors in the bottom line simply use the there is no area of development.
हम लोग बीच में पूछ सकते हैं ना वनीता, पूछ सकते हैं. Yeah, so that is about publication. तुम बताओ what is conflict of interest? तुम वो जो you just walked in ना, तुमसे पूछ. I just wanted to ask, what is the conflict of interest according to you? You had chai samosa? Not too many, I guess. So, what is the conflict of interest according to you?
Financial benefit involved for the author, particular study that might be for example, the company is paying money to publish a particular article.
Correct. So, there can be variable definitions. It occurs when a person has a clash between personal interest and your professional duty, right? So broadly speaking, it can be publication, it can be discharging your professional duty, whatever. And the actions which you take out of that, there is a risk of bias. Mota yahi definition. You can, twist it according to whatever you want, but by and large, this is a definition. Having an interest does not necessarily mean you have a conflict, correct? And the reverse is also perhaps true. Having a conflict does not necessarily mean you have done anything wrong. So that is my perception of it. Your would be different. But again, the idea of having a lecture or anything is it's a dialogue. So, this is my opinion and I will just present you my perspective of it. So having a conflict is perhaps not bad as long as that conflict is managed ethically and properly. So that is the basic root. So I'll focus on industry physician interaction because you guys will be perhaps leaders of institutions tomorrow or having your own practices somewhere. So you will have a lot of interaction with industry, both as physicians, as surgeons, or as whatever. Because we have a unique relationship with the industry. The industry will make products like drugs, devices, which they cannot sell to the consumer or the patient directly. So they need the medical profession for that. We use the products which are sort of made by the industry. So we have a very close relationship, and hopefully our aim is patient benefit. Both the industry and we want it. So it's a two-way benefit. How do you think the medical industry, medical profession benefits from the industry?
So keeping in mind the benefits of the patient.
You can pass on some benefit to the patient, that is one. Anything else? Anybody can think of anything? Anybody? First of all, benefits to the industry क्या है? Commercial benefits तो हैं. It frequently cultivates relationships with doctors who are in a position to give you business. So that is one commercial. It is an inescapable thing. You know, industry is a business house. So it will cultivate relationships with doctors who are in a position to give you business. And any access to a prominent doctor or a physician is considered a good investment by the industry. That is also true. And a good relationship with any particular doctor will translate into more business for the company. So ये तो industry का perspective हो गया. They will want to have a favorable relationship with you. So physician collaboration, as you rightly said, will help the patient. Many interventional branches, you guys would be from the surgical branch, from the cardiology branch, from the cardiac surgery branch. Many interventional branches and especially minimally invasive techniques have developed in partnership with the device manufacturers. Training opportunities. Many will come to that subsequently. There are a lot of fellowship positions, especially in the West, which are sometimes funded by the industry. So this is the way medical profession can benefit. So it's a two-way benefit. But as I said, the goals and the guiding principles vary. Industry ka apna commercial ek interest rahega, which has to be there. So we have to realize that interest and sort of at all times try to steer clear from that professional interest. At the same time, keeping in mind our patient interest super in our mind. So these relationships will begin in medical school. I'm sure internship आपने जहाँ से भी करी है, residencies करी है, you will interact with the industry at all levels. It will continue throughout your lives. You cannot escape from it. And sometimes these lines get blurred. So a relationship that should be ethical may deteriorate into a dangerous conflict of interest. So how do we make sure that those lines don't get blurred? So first of all, a bit of a history. इसका नाम सुना है किसी ने? First of all, it's so difficult to pronounce, इसलिए I don't pronounce it. I tried practicing, but I saw it. So this is William Osler का तो सुना होगा ना? Osler, William Osler, heard of him? Father of medicine बोलते हैं कई बार. Father of nation तो पता है ना? So William Osler. So this was an essay written by him when he was leaving the Penn School of Medicine, Pennsylvania School of Medicine, छोड़ के he was going to Harvard. So he wrote this lecture, essay in 1880s, I think. And I'll just show you the gist of the lecture. He says that physicians may come to rely on seductive pamphlets or literature given by salesmen, industry, who express the most emphatic opinions about topics on which the greatest masters of our art are doubtful. That is, जिसके बारे में doctors को ज़्यादा knowledge नहीं है. The industry sort of wax eloquence about those topics. So this is written by Osler nearly 200 years ago, which we are now realizing. Sometimes the medical industry will give you literature and say कि यार ये product लिखना है, ये drug अच्छी है, but unless you delve deep into it, you might harm your patient, which you don't want. So collaborative settings, especially in hospitals, clinic practices, जो आप करोगे, they are fertile grounds for the emergence of conflicts. This was a seminal paper in NEJM in 1980. If you guys can get hold of it, try to read it. क्योंकि a bit of history is very important. So it will just give you a good perspective on what is the medical industrial complex or medical industry relationship. So they did a survey of doctor industry relationships published in NEJM in 2007. So nearly 90% of the doctors reported some relationship with the industry in the form of drug samples. Where वो तुम्हारे साथ की वो girl अगर सो रही है उसे को neck ठीक कर ले, she might hurt us, right? No, she is awake. Okay. So drug samples, gifts, reimbursements, consultancy, lecture fees, enrolling patient in trial. So there are a lot of freebies which you might get. This is the truth. And physicians in solo practices, we are lucky that we are in an institution. Physicians in solo practices are more likely to be targeted with all these freebies than hospital-based doctors. So usse kaise you can, sort of get involved with the industry as well, but maintain your integrity and reputation as well. So at what levels can conflict of interest arise? अगर doctors, आप doctors हो, so again, आप बताओ, आपसे पूछो, तुमसे, हाँ, किस level पे conflict हो सकता है? Okay, one is you publish something, anything else? तुम भी बता दो यार कार्डियोलॉजी वालों कुछ हैं? Okay, publication में ही आ गया वो. Sorry, brilliant. Who said this? Very good. किसने बोला? अरे सही बोला, मैं पूछ रहा हूँ. हाँ, good. Excellent. So when this fellow, I get very scared when Madam or Vinita listen to my lecture because most of it is repetitive from last year. See.
How much tolerance we have?
Yes.
This is the thing.
How much? Yes. I was hoping I could crack the same jokes, but so yes, you will encouragingly laugh at them again and again. So again, these are random questions which I made myself. Is it right to accept drug samples? Right. Is it right to accept hospitality sponsorship? Is it right to attend sponsored educational meetings? These are just random questions I'm throwing at you. Is educational funding of research by industry a good idea? Are you aware of any guidelines? Because guidelines हम लोग sacrosanct मांगते हैं, for our cardiology thing, ACC, American College of Cardiology, American Heart Association. Similarly, आपके अपने subject की guidelines होंगी. Do we think the guidelines and regulations are sacrosanct? They are above industry manipulation. So we'll just discuss these things. Again, some history thrown in. Harvard Medical School, we think it's an epitome of sort of research and innovation, which it is. Surprisingly, in 2009, when I was also reading for this lecture, this is the American Medical Student Association. It gave Harvard an F grade. F is pretty bad in American lingo. In 2009 for managing medical ethics, which was pretty surprising. And how did it happen? That there was some senatorial inquiry and one of the faculty at Harvard affiliated Mass Gen Hospital, he was found to be taking some financial endorsements from the industry. So the Students Association sort of gave a F grade to Harvard and said that you must pull up your socks and have better ethical regulation at your institution level. So you guys are fortunate that these courses are running here. So that is the reason I just wanted to show this slide, because sometimes you feel ki 3 to 5 hai, thake hue hain, especially chai samosa kha liya hai, so you might be sleeping a bit. But these things will be important at some point of time. So these Joby who is running these courses, they're spending a lot of time, investing a lot of effort in it. So take it a bit seriously. And Harvard was actually not the only school. 34 other medical schools who got a bad grade, but they rectified themselves. So we are discussing at what levels can conflict come. as you rightly said, visits by medical reps to doctors, prescribing patterns, sponsored CMEs, research fellowships, journals. Somebody mentioned Dr. Piyush Sahni ka lecture tha isse pehle, and every time I listen to his lecture, I also learn something. So he told a lot of good things. Conducting trials, he mentioned about trials as well. And of course, practice guidelines. So we'll just discuss these things quickly. First three things. So industry spends a lot of money, invests a lot of money in, hiring medical reps who come and visit you maybe 4 to 5 times a month. And what they think is that if they give you some positive information, as you rightly said, it will increase the likelihood of you writing that drug or that product. So how do the medical reps approach you? Just बताओ, मतलब what do they tell? तुम बताओ यार, cardiology. कुछ बोलो.
Cardiology has lots of reps. Every time I go to the OPD, in
Yeah.
front of the OPD, there are 10 medical reps waiting in the morning. Like yesterday only I had a tip with them.
Really?
The whole path from the first to the second floor, back to bags, and the medical reps are waiting there in the morning at 9:45. So you must be really popular. I was calling you yesterday.
Maybe. Because probably they're not allowed in the department, so that's why they go to them. That is a lame excuse. So, we'll address that issue. Huh? Batao, what do the medical reps come and tell you? I mean, don't tell us in detail, but I just want to, how do they request you for writing drugs? I mean, yeah. Okay, that is one thing. Yeah. Anything else? Bas aur nahi bata. So they will objectify with you, they will reason with you, appeal to your pride ki doctor sahab KGMC mein bhi 10 logon ne likha, aapne likha, aapke pen se nahi likha gaya to kya baat hai. They will offer you gifts, and last is the mercy appeal ki nahi likha to meri naukari jayegi. See, these are the 4 ways. But if you see, this is actually published data in JAMA and in International Journal of Pharmacology, when they polled medical students and interns who have perhaps the most fertile minds, perhaps the most influenceable also. Many of the young doctors said, oh, company materials are a good way to learn, but they were also smart enough to realize that the medical reps might be exaggerating the benefits and downplaying the risks. So they were intelligent enough to realize, and 2/3 of them felt that even if they were offered any gifts or freebies, it would perhaps not influence their practice. So because we have a lot of self-belief in ourselves, so that is why we think so. And we all know that information which they give might not be correct, might not be ethical. And this is interaction between doctors and industry generally, and sale reps specifically. Again, published data, which is surprising. And found that, as somebody rightly said, that it does lead to irrational prescribing. Jitna bhi aap soch lo, hota hi hai kuch na kuch. So we should have some institutional policy and guidelines. Second way in which they influence is, we all know, professional sponsored CMEs. In the last decade in the West only, perhaps India mein aur percentage zyada hoga because we don't have any accountability or any published data, but nearly 2/3 of all CMEs in the West were funded. So you have a concern of potential bias. Now, again, this is a subjective thing. Does attending sponsored CMEs affect prescription patterns? Yes, no, depends on the individual. How many of the guys say yes? Only one?
Be honest.
Please honest. How many of you are dishonest? So again, as Madam rightly said, we think कि ऐसा नहीं होगा. हमें लगता है ऐसा. So I'll just again show you, this is remarkable, when Madam or Vanita give us these lectures, so we also try to read about it. And this is again literature. I'll just show you from early 90s, late 90s and 2000. So pharmaceutical firm enticements on prescribing pattern. There is no such thing as a free lunch. We all know that, right? IV drugs, this was an intensivist poll. IV drugs usage tracked for 22 months prior and 17 months following the industry sponsored CME. And what they found was that alteration in prescribing patterns did happen. Although many of the guys who attended these CMEs said कि ऐसा शायद ना हो, लेकिन होता है at some subconscious level. Again, I'll just quote you cardiology again. So that doesn't mean it happens only in cardiology. Bowman published in 98. So again, calcium channel blockers versus beta blockers. They took on some industry sponsored CMEs and found that the prescribing of some of the related drugs actually did increase. Is a gift just ever a gift? So these are beautiful papers, the headlines grabs your eyes, published in JAMAs. Company sponsored CMEs will obviously highlight the sponsor's product. It will increase the prescription rate because that is why the industry is sort of funding that CME. And meetings were actually followed by a request by the attending doctors to add that particular drug to the hospital formulary and led to changes in prescription practice. So what you said was absolutely right. Well, I think only one person raised his hand, so you deserve a prize. Extra samosa maybe tomorrow. So it will lead to non-rational prescribing on one hand. And some of the proponents who attended this said, okay, it can lead to adverse outcomes, but perhaps if I attend a CME and I learn about a new drug, and I'm convinced about it that it is safe, I go through the literature and all, it might improve patient care. So there are both sides of the coin. We come to the third aspect where industry can get involved, research fellowships, which somebody said. So industry funds a lot of research fellowships in the West as well. And we all, especially for the cardiology, again, closer to my profession, there would be no statins, no drug-eluting stents, or no intracardiac defibrillators. But again, the downside is the more you have this, the more industry permeates into these, the more is it used and how much is it actually benefiting the patient, we don't know. But the funding in research fellowships has increased in the West because the NIH has somehow decreased its grants to good universities. So if you see this, again, published in JAMA some years ago. So the purple bar is the industry. So industry is steadily about 40 to 55% funding of the trials or fellowships in the West. So that is the truth. Funds fellowships. So this is 2004. Dermatology American Association announced a non-traditional funding source for new residency slots in 2006 because they were short on government funds. So they asked some industry sponsor. It said, okay, we'll fund some residency fellowships. Then they slowly expanded the initiative to increase and employ nurse practitioners and other staff. 1/3 of the budget of the American Academy of Orthopedic Surgeons came from the corresponding industry. This is St. Jude Medical, a very important cardiology industry. So it was regularly funding vascular fellowships in the West. And of course, some years ago, in 2015, the American College of Cardiology announced a diabetes collaborative registry with Boehringer. So again, industry collaboration does happen. So all this fellowship business led to a huge outrage in the West. And there were federal inquiries, which concluded three things, which all of us intuitively know, that people were skeptical that a commercial industry sponsor will actually enter into a fellowship arrangement with an institution purely based on philanthropy. Kuch na kuch to unka interest rahega. Young doctors like you might get conditioned at the beginning of their careers, and as we said, prescribe products preferentially. So this takeover of the medical education by commercial industry was perceived to be dangerous. So the association started saying no to industry funding as far as research fellowships in the West were concerned. Quickly coming to the other three aspects, how industry can lead to a conflict of interest in our profession. Journals, Dr. Piyush Sani sir covered, but again, briefly, I'll just add my 2 bits to it. How does industry sponsor medical journals? Anybody? Yellow shirt. You're the only one who's wearing yellow. अरे तुम्हें तो पता, तुमने येलो पहना, वो बताओ तुम्हारे मतलब हाउ डू यू थिंक इंडस्ट्री कैन सपोर्ट अ मेडिकल जर्नल?
Traditionally, how is industry supporting journals? Do you see advertisements? Do you see advertisement in medical journal? That's one way. What else? Dr. Singh also talked about it. They have been writing a paper.
Yeah. So, as Madam said and Dr. Vanita also said, advertisement, bringing out supplemental issues, which is again sponsored thing, publishing charges. We'll come to sponsored trials also in a bit, offering online free subscription to members. There are a lot of ways in which they can support a journal. Again, this is a brilliant paper. In 1992, they took some experts and said that, okay, you guys analyze the ads which are published in leading medical journals. So, American Journal of Psychiatry, Annals of Surgery, huge impact journals, NEJM, Obstetric and Gynecology, Pediatrics. So they looked at these 12, 15 journals and went through the ads which were published in them. And they said, all of them, in fact, said either they disagreed that the drug was the drug of choice, jo ad ne bola tha. Ad should not have been published. It might mislead the readers. It would lead to improper prescribing. So despite that, the ads do get published. So how to rectify that, we'll come to in a bit. So they said that ensure the editors or the publishing board should ensure that the advertisements comply with the standards which should be set by the journal board. And of course, the reprints and supplement business. And this, I think Dr. Piyush might have covered. I missed the earlier part. So they analyze again JAMA paper, analyze the quality of articles published in supplements versus those published in the parent or the major issue. And as we think what was found to be true, American Journal of Cardiology, American Journal of Medicine, all cardiology journals, American Heart Journal, found that trials which were published in the major or the parent issue, they had a much higher or superior quality as to that published in the supplement journal. By and large, this was happening. I'm not saying it happens always, but it happens. The fifth conflict of interest, in my opinion, as sir also said, conducting trials. Any idea what is a seeding trial? क्या हो सकता है seeding trial? तुम बताओ यार, last row में third. Yeah. तुम third, तुम ही. Switching trial क्या हो सकता है? Guess, some random guess. Switching trial क्या हो? एक पर्सन ए दवाई पे या बी दवाई पे स्विच कर दीजिए. And seeding trial, company conducted trials simply to get doctors to prescribe. They are, seeding the idea in their mind. Switching, patients switch from their usual treatment to new treatment. So these are not very high quality trials. Physicians are paid, incentivized for these. They rarely get published. It is only for product endorsement, ताकि वो जाके बताएं कि ये हमने के doctors में किया था. And so these are not very high quality trials. And if as young doctors you are future, you are invited for this, so probably stay away from these. So again, data industry does influence drug trials. Industry trials are usually favorable. They selectively publish their data of inferior data या जो side effects वाला data होगा, that is never get published. They withhold knowledge of adverse reaction, adverse drug reaction, and as Dr. Piyush also said, using ghostwriters. He talked about ghostwriters, so I'll not spend too much time on it. I'll give you three stories: Rofecoxib and Vytorin. कोई है? What is Rofecoxib? क्या होता है? मैडम है, ध्यान से बोलो. हाँ बताओ भैया. And Vytorin is a statin. तो मैं दोनों अपनी कार्डियोलॉजी भी बताऊंगा, ऐसा नहीं. So this was Vigor study. Madam would be aware of it. Published in NEJM. Rofecoxib versus, it's difficult to pronounce, versus naproxen. So what they said was that both drugs had similar efficacy, and Rofecoxib, I have difficulty pronouncing it. कोई इसका trade name नहीं. Vycox था ना इसका पहले West में. So, it was found to be having lesser GI effects. They concluded it fine. And they also said that incidence of MI, myocardial infarction, was lower in the naproxen group. Right. So these are the two things you remember. And on the basis of this drug got widely published and started getting used in patients of rheumatoid. कि उसके GI effects कम है और naproxen के MI was lower. So it started getting used a lot. So then slowly data started coming in. Expert points to be learned from this controversy, risk of cardiovascular events. And what they found was, at some point of time, subsequently, it was withdrawn from the market by the makers. And by that time, I'll just tell you. So what they found was that there was increased risk of MI, which was even found in the parent study. तो उन्होंने डेटा को स्विच करके ऐसे बताया कि naproxen had lesser MI. Actually, the parent drug had more MI. So this was substantiated later on. And the findings indicate that this drug should have been withdrawn several years earlier. So it's pretty shocking. And by that time, the sales had reached about $2.5 billion in 2003. जब तक withdraw हुआ. So this is actually published trials which get sort of sometimes selectively manipulated. And subsequently, following again a senatorial inquiry, there were damages which the company had to pay. I'll just come to a cardiology trial. Enhanced investigators, those from cardiology side, would be aware of this trial. A lipid lowering drug is simvastatin. So what they said was, we'll give simvastatin plus ezetimibe, which is again a dual lipid lowering therapy, versus ezetimibe alone. And the primary outcome was some mean change in carotid intimal thickness or something. And they found that combined therapy did not result in significant difference. So इससे आप summary यही लेके जाओगे कि ezetimibe is as good as, this thing, simvastatin alone is as good as simvastatin plus ezetimibe. So bring your attention to this, that a combination therapy pill costed $100 a month. Simva alone costed $6 a month. So basically Simva alone was as good as Simva plus ezetimibe. But the American College of Cardiology in 2008, after 2 weeks of the journal of the article getting published, said that this was an imaging study, which it was from the beginning, not a clinical outcome study. Major clinical decisions should not be based on the trial alone. And patients should not stop taking the prescribed medication which they were continuing. And further research is needed. American Society of Cardiology also endorsed the same thing. So in my message is not that it is happening in some branches. You should be aware that it is happening at multiple levels, and it does happen. So when New York Times sort of investigated this, they said that the manufacturers, which was Merck, had the results of the trials 2 years prior to releasing them. And you remember the cost, $6 versus $100. So this was again a senatorial inquiry, very famous, you can Google it. And they found that the company had invested in a 6-week public relationship blitz. This was called the 49 plan, wherein doctors were requested, जो मैं बात कर रहा था, switching trial, from switching patients to Vytorin or combination, cheaper जो statin ले रहे थे, उससे आप switch कर दीजिए. And Merck and its foundation had paid huge amount of dollars to the American College of Cardiology during their conferences. So they were censored. Finally, simvastatin alone started getting prescribed, but this is happening. Last conflict of interest, we were discussing about guidelines. So you see, professional medical associations have often endorsed bewildering products. You'll be surprised to know, 2009, the American Academy of Family Physicians announced that their partnership with Coca-Cola to reduce obesity. So they took funding from them, and when they were asked, उनका जो chairman है, Doug Hunley, he said, पहले भी we have had relationships with Pepsi and McDonald's. So, this is the defense, which is pretty weak defense, just like what I said to ma'am, कि department में नहीं आते, OPD में आ जाते हैं medical reps. So again, before I end, Does the pharma industry influence guidelines? Again, I'll show you published data across 3 specialties. Gabapentin, this is German Society Regulation MAH. They manipulated the society study data and got it to enter into the German guidelines by manipulating data. And how did they manipulate? The primary endpoints were changed, unfavorable data were not reported. This is the anti-psoriasis drug, again, which was judged more favorably in the S3 guidelines, which was the German guidelines, than in a guideline endorsed by NICE. And when they delved deep into it, it was found that 65% of the authors in the German regulatory guidelines had some sort of financial links, while in the NICE guidelines, none of the authors had any so-called financial conflicts of interest. And this is nephrology, they would be aware of this. These are renal guidelines published in 2007. They increase the target hemoglobin range from 11 to 12 to 11 to 13. And once you increase the hemoglobin range, it will lead to increase endorsement or prescription of ESP, erythropoietin stimulating protein, and led to massive increase in the prescriptions. And again, Amgen was the major founding and principal source of the KDOQ guidelines, and that was also the manufacturer of ESP. So again, this was subsequently revised. Do practice guidelines author report conflict of interest? Again, widely published data, less than 50% did report conflict, 15% had multiple conflicts of interest. So as young guys, you might be having questions in your mind about the objectivity of a guideline, and of course to the changes in cost, changes in practice, and perhaps public harm it may lead to. But all this is older one. So subsequent steps have been taken and things have improved. So what are the steps to be taken? And most doctors agree that we should have some rules on industry interactions to avoid potential conflicts of interest. So as far as medical reps are concerned, as Madam rightly said, have policies that regulate site access by appointment, prohibit acceptance of any gifts, whether on-site or off-site. Drug samples, again, what Harvard has done, published data reveals that samples, agar doctors ko milte hain, they are not actually passed on to the needy. So what the Harvard guys did, they said that it should be left at the center's pharmacy, where they can be evaluated by the pharmacist team and found to be good. Then you can have a central committee to find out, how that drug can be distributed, which seems to be a very wise thing. CMEs recognize that, as we said, no such thing as a free lunch, have policies to manage industry financial support so that whatever interactions you have with the industry, they are productive and principled. So if at all there is an industry sponsored CME, if at all, then have a central office through which all funding can be regulated. And second thing, which is more important, the committee should have members who are free of industry ties and members of CME who disclose industry relationships should be recused from having part in any say in that CME. So that you have control over the scientific content, the speakers do not have any company presentations and have audit mechanisms so that you are sure that 6 months down the line, these guidelines are being followed. Funding for fellowships. Remember that, again, no such thing as a free lunch. So you have to have some degree of transparency. If at all a center has a research fellowship, which this is now happening in the West, supported by appropriate documentation, have some institutional policy in place, and selection of the recipients of such funds must be at the sole discretion of the hospital, not by the industry. Journals, we discussed this, you can have a bias. The scientific content of such sponsored journals or sponsored articles would be very low. So develop guidelines to ensure that best practices are followed. So BMJ, what it has done is, most of the BMJ USA is still paid for by advertising. But what they have done is they have laws which control the claims which are made in the advertisements. The editorial team, however, does not attempt to review the claims made in the advertisement, but it encourages the readers to criticize if there is any false information and encourages them to complain to the authorities also if the thing mentioned in the ad is not correct. Trials. So again, Dr. Piyush must have discussed, Dr. Vanita was mentioning, industry funding has to be mentioned. No academic participant should be accepting any honorary or speaking fee. Only trialists should have access to the data. And no company rep, of course, can sit on the executive committee of the trial. So what have societies done in the West, especially the cardiology societies? I'm sure others would have done the same. You have, of course, a formal conflict of interest, including the leadership. Those with a definite financial conflict should be recused. Those with a conflict of interest who cannot be divested from the constitute committee, they should only have a minority say in the making of the guidelines. And only members without a definite conflict should formulate the final guideline. Only then you will have some objectivity. Important among this is, this happened with the hypertension guidelines. A minority report from panelists who have dissenting opinions may also be published with these guidelines, so that at least the reader can sift through the data and decide on his own what is true and what is not. Lastly, coming to legal sanctions. So this happened in the West. You should be aware of it. This is the Sunshine Act in 2010. It mandates public disclosure of payments or transfers to doctors by the medical companies, and it is actually put in public purview. Any consulting, honoraria, grant, research, including gifts, etc., is actually up on the public domain by law. Still, this law does not prohibit interaction with the industry. It says that financial ties do not necessarily signal wrongdoing, which is again a very gray statement. It says that the data is available to the public. So many of the doctors, after the publication of the Sunshine Act, are staying away from financial ties with the industry, especially if it is likely to affect their practice, which it will. These are the exempts in the Sunshine Act. Educational materials which benefit the patients, samples, loan of devices for trial period evaluation. So these are the 2-3 things which are exempt in the Sunshine Act. Lastly, coming quickly to MCI, इसके laws आपको पता होना चाहिए. It prohibits gifts, travel facilities, hospitality, money grants. Funding can be received through approved institutions by appropriate laws. Institutional laws should be disclosed. Clearance of research proposal by relevant ethics committees, if it is an industry sponsored thing. And freedom to publish the results of the research in the interest of the society by inserting such clauses in the MOU. This is what the MCI also tells us now. Again, this is a very statement which maybe madam can talk about it later. Can be interpreted in many ways. It says it may work for an advisory capacity, consultants, researchers, in any other professional capacity, provided professional integrity and freedom are maintained, patients' interests are not compromised, and you are within the law. So it does permit you, provided you respect these 3 rules. And you should, of course, not endorse any drug product publicly, maintain professional autonomy. So these are the 2 things. Does putting too many restrictions have an adverse effect? So this was the unintended impact of the Sunshine Act in US. Medical CMEs markedly got curtailed, especially in Massachusetts, where this law was first implemented in 2010. Many visiting professor programs and PG programs were cancelled initially because many were industry funded. And since disclosure of payments to doctors did lead to some reduction in industry research, the doctors were of the view that productive collaborations might go down. And people were scared that future innovations might also dip down because of these strict legal sanctions. And this Newsweek poll right after the Sunshine Act said that the American public was also concerned about this, and many of the people in the public also supported the collaboration of doctors with industry so that it can help therapeutic advances. Many tight restrictions can reduce innovation, but at the same time, this conflict has to be ethically managed. So final conclusion or my own opinion about it is that medicine or surgery or any other branch is very, very technology intensive branch. It need a lot of research, quality improvement, and we might need some support of industry for that. Industry provides some technical scientific support, but it also will lure you with incentives. It will. So our medical curriculum should have some institutional guidelines about adopting appropriate interaction with the industry. We should have some institutional policies, which hopefully might get developed with time. At the level of the regulatory bodies, have guidelines which urge the doctors to stick to ethical conduct. However, there is no directive towards the pharmaceutical industry. So that is unfortunate. Despite the MCI formally coming up with these guidelines, many are not aware of these rules. So you should all read these MCI guidelines. They are on the net. It is not the prerogative of the industry to make you aware of these fresh rules. They always come and say, Doctor Sahab, aap le sakte hain part isme. But again, read these yourself. So there has to be more visibility of this MCI program on our site. So this is what Harvard did. Drug samples not acceptable unless for patient use. As I said, they made a central drug formulary. No gifts except educational items. Site access completely regulated, by appointment only. At a personal level, of course, sir also mentioned, disclosure of conflicts is very, very important. Difficult to set a monetary value that would render a gift unacceptable. Sometimes people ask, what is the monetary value which you should take or which you should refuse? So again, difficult question to answer, but everybody has to have their own sets of questions and answers. So first of all, understand what is the purpose of this offer by the industry to you. What would my colleagues think if I say yes to this? And lastly, what would my patients and public think if they come to know? So if these three questions you can answer, then I'm sure you'll be able to manage some level of conflict of interest in an ethical manner. So remember, your reputation is always driven by what people think about you, what your patients think about you, what your colleagues think about you. So healthy relationships can exist with the industry. We have to be very clear what that relationship is going to be. It is a relationship of trust between our patient and us. So we should not be eroding that trust by collaborating with the industry, however necessary it may be. So I'm not saying give a collective industry hug. OPD mein jaake unko hug karne ki zarurat nahi hai. But we should not become so tied to industrial support that we can function without that support. Right? So we can function without them, and if we need them, we should be engaging with them on our own terms. So rather than restricting relationship, I think focus should be on transparency and ethically managing these relationships. This might help better than potential threats of sanctions to doctors. So that is my perspective. Thank you.